All right, so just to kind of recap and review some of the hyperthyroidism, it's the opposite. We spent a lot of time on the hypo component, but the hypo had cold intolerance, the hyper folks have heat intolerance, and that's because their body temperature is elevated. So instead of having constipation, they're going to have diarrhea, so their GI system is going to be overactive. So they'll feel hot and sweaty, they can't tolerate heat, their blood pressure, heart rate, that'll be up. So basically that's because the sympathetic nervous system is, going full throttle. Skin will be a lot more smooth, more soft hair, and that's because of the increased blood flow, where we had hair issues before and dry skin with hypothyroidism. They are at risk for cardiovascular dysrhythmias, which is like an abnormal heart rhythm, like atrial fibrillation. Where their changes are in personality, it's more insomnia, they're restless, they're moody, and that's because of the excess or the increase in the metabolism component. So do you remember causes of hyperthyroidism? Somebody has to answer.
Too much T3 and T4, or too much excretion of the TSH.
Right, so usually if someone has hyperthyroidism, what's like the number one issue they will probably experience with that? The one with the bulging, protruding eyeballs?
Expothalamus?
Right, but what's the condition?
No, the Graves' disease.
Graves' disease. So is that an autoimmune disease?
Yes.
It is. It's an autoimmune disease from antibody and the immunoglobulin production. So their thyroid stimulating immunoglobulin kind of acts like the TSH on the body. Therefore, it increases the thyroid hormones. And then you have those protruding eyeballs. They could have a goiter. So there's a lot of different things. The skin issues, their skin is more waxy, almost like orange peely in appearance, primarily to the legs and the feet, okay? What about thyroiditis? What is thyroiditis? Itis means?
Inflammation.
Inflammation. So this would be an inflammation of the thyroid gland. So that could also be a potential problem that the individual may experience. And this is, the cause of that is the thyroid hormone is leaking into the bloodstream or to the circulation. And it's inflamed, causing the release of that hormone directly into that bloodstream. So that's another one. What about too much iodine consumption? Would that be a reason why a person would have hyperthyroidism?
Yes.
Yep. So this produces the thyroid hormones and it helps make the T3 and 4. What about a goiter? So a toxic nodular goiter. Is that an autoimmune issue?
It can be.
That one usually isn't. So usually there's nodules or growths that are independently functioning to hypersecrete thyroid hormones. So it's kind of like if you have an extra nodule on, we'll say like your wrist. So it doesn't necessarily have anything to do directly with the skin, but it's going to cause a skin blemish. So you can have nodules on things that's actually working on its own, not necessarily working in conjunction with the actual organ. Does that make sense? So how do we treat it? What's our treatment?
You want to stop the excretion of T3 and T4.
Okay, so what medications do we give?
Is it
Methimazole.
Yeah, methimazole. That was the most common.
And then
especially used to treat Graves. Okay, and then we have the uracil, the PTU, which the concern there is that they have to monitor liver functions test because they're at high risk for liver failure when they receive that particular medication. Other things that they would have an issue with is it's going to affect the blood system. So their white blood cells will go down, putting them at risk for infection, and their red blood cells will go down. So that's going to put them at risk for anemia. Can they stop this medication abruptly?
No.
No, they cannot. So that will lead to issues. Should they take it the same time every day?
Yes.
Yes. Should they have like a lot of seafood and dairy and seaweed?
No.
No. What about aspirin?
No.
No. So no aspirin. So then we're going to look for other signs of hypothyroidism when they're on the medication, because if they take too much of it, it's going to swing them on the other side, if you guys remember correctly. So then what are signs and symptoms of hypothyroidism?
Weight gain, cold intolerant.
Okay, cold intolerance, weight gain. So some of the physiological things you'll see, they'll be more tired, where before they remember they're restless and they have insomnia, but they'll be now more tired, they'll be exhausted, and then their temperature will be lower, because here their temperature is actually higher, right? So what type of interventions besides medications should we also do?
The hypo?
This is for hyper.
Oh,
We were talking about the hypothyroidism signs and symptoms because of the medications they're on, right?
oh,
So we want to
gotcha.
make sure that we're not swinging them from hyperthyroidism to hypo. So I was just reviewing what would be those signs that you would expect to see. But now we're still on hyper. So I'm just talking about some of the other nursing interventions besides the medications. So if they're hot, we need
Cool
to
them down.
cool them down, keep them comfortable. Okay, quiet environment, right? You could potentially give them sedatives because that'll help calm them down as well, decrease heart rate. So some of the signs and symptoms they'll focus on. Should we get weights every day?
Yes.
Absolutely. Absolutely. And then we want to tell them to monitor for like thyroid storm, which is life-threatening. So it's that untreated hyperthyroidism, or if they've had a thyroidectomy, then we need to look at that as well. Okay. So now instead of they will still have those same signs and symptoms of hyperthyroidism, but they'll be a lot more exaggerated. So blood pressures will be much higher, heart rate would be much higher. They'll be much more restless when they have thyroid storm. Okay. Anything else we can do for them? What's a permanent cure for hyperthyroidism?
The iodine.
Which one?
Radioactive?
It's the radioactive iodine.
Yeah.
So that particular one, they can't, once they do it, they can't undo it, right? So it's a permanent cure, not for, people that are pregnant or, nursing babies and things like that. But they kind of get that metal taste in the mouth. And I remember talking about this at the end of the lecture. The other thing, they can take the thyroid gland completely out, right?
Yeah.
So now we have to watch for thyroid storm. And then we need to look at the parathyroid. So now we may have a calcium issue. Will calcium be up or down if we take the thyroid hormone out?
Down.
It'll be down, okay? What are some things we can tell them after they have the surgery? So what is, that they might want to do to prevent things like pneumonia?
Cough more.
Okay, cough, did you say cough?
Cough, yes.
Okay, so it's called pulmonary toilet. So it's cough, deep breathing, splinting the wound. So normally if the patient's mobile, they would turn themselves, but turn cough and deep breathing prevents the lungs from getting atelectasis, which is basically alveolar or lung collapse, right? We also want to monitor for respiratory distress. So, because after any surgery, there's a risk of swelling, there's a risk of bleeding, right?
Mm-hmm.
So we should have some things at the bedside, like a trach kit, just in case. Make sure we have some good oxygen. We have oxygen, we have suctioning available, but we need to make sure the gauge is there, it's operable, those types of things. And then keeping the patient more elevated, more than supine, so those things, they don't have issues there. And there's several different issues that can happen when you have your thyroid taken out or surgery in that area. It's very intricate. There's a lot of intricacy in that particular surgery, which can, it can affect their voice box. So they may not get their voice back, or they may come back with a different voice than the one they had before. It could be more hoarse, and it may stay that way permanently. So it could be temporary or permanent. So those are some other things that you want to, as a side effect or a risk factor if patients decide to get their thyroid taken out. Just kind of food for thought on that one. So any other questions about the hyperthyroidism?
Not for me.
Okay. All right, so tell me a little bit about what you know for the parathyroidism. So you looked at your PowerPoints, and somehow if there's an issue. So if you have hyperparathyroidism, what's going on? It's producing too much what?
Calcium.
Calcium.
Okay. So, well, if you want to talk about the function, let's back up. So this will be a good place to start. So for the function, it modulates our calcium and our phosphate levels, right? It also works on our GI system. So it helps with the absorption of calcium, and it also acts on the release of, acts on the bone to release calcium if need be. So in someone that has hyperparathyroidism, or if one of the 4 glands, if it starts to get bigger, and then that means they have some type of tumor, right? Then there's going to be a disruption in the feedback system. So then we're going to inappropriately secrete parathyroid hormone at higher levels. Causes, I've talked about one, adenoma, which is the main cause, and adenoma is a tumor. What about chronic kidney failure? Could that be a cause? Yes or no? It's a 50-50 chance.
Yes.
Absolutely. So what happens in with chronic kidney disease, so the parathyroid gland hormones, or the gland, responds to an inappropriate reduction in the calcium that's in the extracellular area. So now this concentration increases, and calcium is immobilized by increasing the absorption in the intestinal tract. So now the gland becomes more hyperplastic, and that's because of long-term stimulation and release of the parathyroid hormone. But that's all related to kidney failure. What would make a lot more sense to have hyperparathyroidism is if you don't have enough what? Calcium, or you don't have enough. What helps you absorb calcium better?
Vitamin D.
Vitamin D. So those 2 deficiencies can now increase your parathyroid hormone to make extra calcium in the body system. Sometimes they don't know. It could be genetics. If they don't know, what's that word when they don't know for sure? It starts with an I.
Idiopathic.
Idiopathic. So they may not know for sure, but it could be genetic. I mean, it could be laxative ingestion. Okay, so there's some other things that can happen. What folks tend to have this issue is that the majority of the cases, is it found in pediatrics? Is it found in young adults? Is it found in middle-aged adults? When is it most often seen?
We go with older adults.
So if they're 50 and above, so that's when you'll start seeing it. Who's affected more, men or women?
Women.
Women.
Women?
Yep, women are affected. So a complication of hyperparathyroidism would be osteoporosis.
Porosis.
Yeah, I did want you guys to finish that, so it wouldn't be me. So yes, there's other risk factors related to it. So things that you would see would be like polyuria. You may see hematuria because they can have kidney stones. Osteoporosis, they could have anorexia, polydipsia. So there's a lot of different signs and symptoms associated with it or that they may complain of. All right, some other findings, muscle weakness, because calcium also plays a role in muscle contraction. They would probably have bradycardia and high blood pressure. So that would be their physiological signs. So we could check their ALK phos for labs. We could do a calcium level. We could do a parathyroid level or hormone test. We can look at vitamin D. So those would be things to help us navigate where patients may, if this is a hyperparathyroidism. So give me some things we could tell them to do to increase their calcium or to decrease their calcium, not to increase, but to decrease.
Diet.
Okay, so what about the diet?
Less calcium based. So we got to take out some of the milk and
Okay.
dairy aspects.
So we talk about that, so milk and dairy, okay? If they're taking supplements, then they may want to pull back from that, right? Because some folks take calcium supplements. So we can have them pull back from that component. What else?
I'd say avoiding the sun because of the vitamin
Usually
D.
it's because of deficiency, and if they actually go in the sun, wouldn't that stimulate vitamin D?
Yes.
Okay. But we do want to restrict their calcium intake from that standpoint. So they usually give them something like calcinet, which is a vitamin D analog. So it will suppress the parathyroid hormone. If it is a vitamin D deficiency, then they'll give them the vitamin D supplement. They could do estrogen therapy as well and give them normal saline if they have hypercalcemia to expand their extracellular volume, which will allow them now to pee out calcium. They can excrete it out. If it's really severe, we can give them things to reduce bone turnover. We can give them things to decrease calcium in the PTH levels. We can also give them Lasix or furosemide. But we give that to patients that have good hydration status. We just don't give it to them if they're dehydrated. Another thing they could do, since it's hyperparathyroidism, they could take out the parathyroid glands. So they could do that as well. And some have taken them out and then stored them in the patient's body, but like in the forearm, in case they may need them later. So that has also been utilized as well. How much liquid should they drink per day? How much PO fluids?
At least 2 liters.
3. Okay, so they need quite a bit of liquids, and most of that's to flush it out. Okay. What else can we do for them? We talked about meds, loop diuretics, group their activities, kind of promote rest. What else do we need to talk to them about? Are they at risk for falls?
Yes.
So they're at risk for falls. So we want to try to reduce injury, stability, because the calcium, remember, it's not in the bones. It is where it shouldn't be, in the bloodstream. So vital signs, that will be a normal. INOs, that would be a normal. Calcium and phosphate levels, that would be normal things that you would actually do. Their cardiovascular status. And then we would look at things, you know, if they have their parathyroid taken out, then we want to look at neuromuscular function. We want to look at edema in the neck area post-surgery. Then they have something called Chevestek's sign. Have you heard of that before? It's a spasm or twitching that could be in the facial muscles. So if you kind of tap the facial nerve near the lower jaw, then they'll have muscle spasm or twitching to the face. All right, you guys are awfully quiet. So what else can we do for them? Anything else that you've read about? So if they have hyperthyroidism, if we do too much, give them too much Lasix, they can now have what? Or not thyroid, hyperparathyroidism, which means their calcium levels would be high. We could actually swing them in the other direction, correct? And make them hypoparathyroid or have hypocalcemia. Does that make sense? And if not, say, nope, doesn't make sense. Am I on here by myself?
It makes sense. It doesn't make sense. Explain it to me. Let me help everybody out.
So, okay, remember like the hyperthyroidism. So when you take the medication, if they get too much, then they will start to see signs and symptoms of hypothyroidism. It's the same thing here. So if you have hyperparathyroidism, and if we overtreat, then now we could put them on the other pendulum side, which would be hypoparathyroidism. So now we would be, you know, looking at, you know, brittle nails, dry skin, you know, loss of eyelashes and fingernails. They could have tetany, so increased deep tendon reflexes. So there's a whole different process where the other one, you wouldn't have deep tendon reflexes. Does that make sense? Irregular or, you know, slow or rapid pulse. There's a lot of, so now we're pushing them in the other direction. So even when we talk about fluid and electrolytes, and I think this is the hardest thing for students to understand when you're talking about something high and low, that you monitor for signs and symptoms of their opposite. It doesn't mean they're going to get it, but you know, if they start experiencing those signs and symptoms, if they get too much of it, then you need to think about, okay, we've given them too much. Now we've swung them in the other direction. So you still, just because you give somebody something and you tell them, hey, go home, take this medication, you're still monitoring for them going into the opposite condition for which they're being treated for. Does that make sense?
Yes.
Yes.
So when I say, you know, so, and I'm going to talk about that a lot, because students will learn one thing and they'll leave it in a silo. Even if it's in a silo, you still have to look at it as it can swing to the other direction. It's still a pendulum. So if it swings the other direction, then you're going to have an issue. So think about, you know, what could push the patient in that direction. So, and it doesn't mean it's your fault per se, and the dose may be too high for what they need. Or the patient may forget they took it and then take an extra dose. Does that make sense? So those are your nursing responsibilities. So if you're giving them something, we want to make sure we're not taking them to the other direction, okay? With hypoparathyroidism, which is the opposite, now we're actually going to talk about it, we have a deficiency in the parathyroid hormone. So the secretion by the gland is decreased in the periphery. So it could affect the calcium balance. It could affect neuromuscular cell function, causing the patient to have now weakness, muscle weakness, or paresthesia to a particular extremity. So other things that could cause parathyroidism, there's several that was listed in your textbook. Do you remember any of them? So accidental removal or injury to one of the parathyroid glands. There have been folks that have had thyroidectomies done, but the wrong one was taken out. But when you take out the thyroid gland or you radiate the thyroid gland, you run the risk of doing what? Damaging the parathyroids. Does that make sense? Neck surgery, family history. So if I'm studying for something, I want to look at what is it, how is it defined? That'd be one. Two, what's the pathophysiology behind it? How does this condition happen, right? Then I want to look at causes or risk factors. Then I want to look at what would be my signs and symptoms. So like I talked about before, dry skin, brittle nails, coarse hair. Some may have alopecia, cracked or decayed teeth, stained teeth. There's a lot of different ones, but I would kind of, get the ones that are mainstay. Then I would look at my labs and diagnostic tools. So what type of labs would I need to draw? Calcium levels, phosphate levels, radio immunoassays that you're going to need that for the PTH. And if you're doing it for someone with hypoparathyroidism, then the radio immunoassay will be decreased. The calcium levels would be decreased. The phosphate levels would actually be increased. What you'll learn in fluid and electrolytes, calcium and phosphate are indirectly proportionate. Do you understand what that means, right? Or indirectly related.
One's up, the other one's down.
So if calcium's down, phosphate is up, or phosphorus. So other things we can look at are, doing an EKG. So with an EKG, that would be, they would have some abnormalities in their QT segment and their ST segments. CT scan, and then maybe do a bone density to see what's going on, since we're talking about calcium and these are the areas that's being affected. Then we look at giving them foods high in calcium, or we could give them vitamin D to help increase calcium absorption. We could give them calcium salts or calcium gluconate. We could give that to them IV. Calcitrol, we can give them magnesium replacements. So there's several things from the medication standpoint that you could look at. Then my next piece, when I'm studying, I will look at what's my interventions. So we've already talked about the 10% calcium gluconate. We're going to give that slow. We're not going to give it fast. Yes, all medications can't be given fast. And then looking at ABCs, monitoring cardiac, put them on a cardiac monitor, see if they have any abnormalities, putting them on seizure precautions. Then looking at their neuromuscular status to see if they have any Trousseau sign. Looking at deep tendon reflexes, and what did I say their deep tendon reflexes would be earlier? Would it be increased or decreased? It'd be increased. So with that being said, tell me what you guys are doing so I can help you, get a little, at least have a game plan on a plan of attack. So tell me what you all are doing, and this may help your classmates as well.
I'll be the first one to tell you that I did not study parathyroid, so that was my mistake.
Okay.
But I have been doing a small, what I call a roadmap. I'm going on the Lippincott and looking at the interventions and diagnosis, and then taking small aspects from that, and then making like a little one-page sheet.
Okay.
And then reading.
Okay. Have you been answering the raising the bars?
I've been trying to do as much as I can on the top of my head, see what I can retain, and then I'll go into the book and then
Sounds
start
good.
trying to them that way.
Okay, so what about the rest of you guys? What are you guys doing?
I as well. I have I've been doing like I put the subject in the middle, and then I write the risk factors, the causes, and everything. It's like a little web that I have going on, and then I've also been doing the raising the bars.
Okay, all right. What about
I've
you?
been,
Go ahead.
I've been doing the thing, kind of going through the ebook links and just kind of go over them quickly and try to find out what's important, and then I'll go ahead and save those important details, and also doing raising the bars. I'm not trying to really answering them. I'm basically filling them out and then kind of going over it over and over as much as I can.
Okay. What about you, Miss Stephanie?
I was the one that did the subject in the middle with the
Oh, okay.
what's on type. Yeah.
Then I'm Miss Tamara. Or Tamara. She may have stepped away. All right, so I typed this earlier before you ladies got on to Jacob, because it was just, you know, you want to get a generality. Do you guys read before you come to class?
Yes, I do.
Okay. So you have to read before you come to class, because if you're reading after, then you're already behind the 8 ball and you easily get overwhelmed. So try to read before you come, at least do the videos that's posted on there. Look at the PowerPoints, you know, see what you can make of it, heads or tails, and then, you know, then you have lecture, and then it can help fill in the gaps. I can tell you now, case studies work tremendously. Most students don't like it. You know, just like, tell me what I need to know. This is too much. I got to read and I got to start thinking. But this is what this is all about. You have to start thinking and putting these pieces together. So when you're trying to understand the material, then you really do have to, you know, kind of get a little bit of information before you come to class. Then, you know, have a set plan. You need to study with folks. So, you know, versus saying, oh my God, this is way too much, then this is what I would be saying. Hey, let's get a study group together. And it doesn't have to be the whole class together. I mean, because everyone's schedule is different. But then you want to start, if you can explain, so if you have parathyroidism, this is the pathophysiology, this is the risk factors, people that have it, these are the causes why. These are the signs and symptoms. These are our nursing interventions with medications. These are the labs that we need to do. Does that make sense? If you can explain that to people, then what does that say about you?
We're gonna pass the class. I'm just kidding.
You understand it. You understand it. So it shouldn't matter what, question you get. You should actually be A-okay. So when you can explain it where folks can understand it and you understand it, then you are already ahead of the game. So those are the things that you want to look at and understand for yourselves when you are trying to prepare for something like this. And it is a lot of information. And you know, that's why I try to be honest day one. It wasn't to scare you, just to say, you know, if you don't start digging in now, then you're going to be so overwhelmed. So, you know, use your resources. If there's case studies in your resources that are interactive, do that. You don't need to look at the journals or anything like that. You know, there's enough for you to look at, trust and believe. Okay, so let's see where I want to go. I think I did this one already. I can't remember. I don't think we did this one. I'm going to, there's a questions and case studies, and it's over metabolism, but it's actually over diabetes. We covered gestational diabetes, and then I'm gonna show you something in Lippincott, because there was questions about, we talked about needle sizes, and then we also talked about the insulin. So there's a chart in your, on page 1469 that I'll show you. And you just have to have an understanding. You don't have to, you know, memorize it point by point by point. But, you know, you need to know what a rapid acting insulin is, what a short acting insulin is, what's a very long acting insulin, and some of the safety measures regarding it, which we already know it's a 2-person check, right? And then I did talk about the different syringes, so that way you should be looking for that. So anytime you're giving insulin, you need to use an insulin syringe. So we'll do something else with parathyroidism, you know, next week. This will give you time to kind of get in the material, but remember, even though your test is delayed, we're going to move on to gas exchange, so that, you know, we're not going to go backwards or in reverse. We're going to literally keep moving. We're going to keep moving forward. So let me pull up this particular one, that, since this is something we did cover, so this should maybe be reviewed for you guys. And I'll share my screen so you can see what I'm looking at. So you should see a PowerPoint come up. And here we go. It should start here momentarily. All right, come on. There we go. All right, so first question. This is basically what we're doing. This is our objectives, okay? So we'll make sure that all patients, make patients responsible for their management of their condition, involve the patient's family, enable the patient to become the most active participant in the management of diabetes, and then provide as much information as soon as possible to prevent complications of diabetes, like retinopathy, blindness, and kidney failure, heart attacks. So, all right, so this one we should know. So we have a patient screen for diabetes, has a fasting plasma glucose of 120. So the nurse explained to the patient that this value is what?
Normal, kind of.
Borderline.
Yeah.
All right, so it's normal. Is that what you're saying, that it's borderline?
Yes.
So if it's borderline, which of those 4 answers would be appropriate if it's borderline?
Three.
So exactly. If it's not normal, then we need to tell them we have an impaired glucose tolerance. This is an early stage of diabetes. And I meant to have you answer this question, but I skipped right through it. So I'm gonna go back. So what's the goal here of diabetes education? Is it 1, 2, 3, or 4?
I say 3.
The answer is 3. Somehow I took myself out. There we go. Correct. Okay. And we said this was 3. All right, this one. Type 1, calls the clinic with complaints of nausea, vomiting, and diarrhea. Is that going to be good?
No.
No. So it is most important. So this is, we're here, we want to find out what's going to be most important that the nurse advises the patient. What would be the most important thing to tell the patient to do? This is a type 1 diabetic. Do they make insulin? Yes or no?
No.
No.
Okay. So since they don't make insulin, should they stop taking their insulin?
No.
Okay. Is the patient going to do any strenuous exercise? I mean, why they have nausea, vomiting, and diarrhea?
No.
No.
Nope. And for adults, while we're talking about illnesses and stress, what happens to their glucose level when they're under stress of any kind, whether it's work, job, or family, or health?
Spikes.
Does it go up or down?
Up.
It goes up. For adults, your blood sugar goes up when you are under stress, okay? For kiddos, they have a high metabolic demand, and the most metabolic element that they use is glucose. So under stress, they're gonna have hypoglycemia, okay? So their blood sugar level is gonna be low. Adults will be up, kiddos will be low. All right, so we've already ruled out 1 and 4. So should we tell them to drink cool fluids with glucose content?
No?
No, absolutely not, because they don't have any substance. Whatever they had is going out. And if glucose actually can make you go to the restroom. So we don't want to do anything like that. Okay, so the only answer there is to check the blood glucose level every 2 to 4 hours. Because we're trying to determine the effects of the stressor on the glucose level. All right, so cardiac monitoring is initiated for the patient in DKA, diabetic ketoacidosis. The nurse recognizes that this measure is important to identify what? So do any of you guys know anything about cardiac monitoring? And if so, what? And if not, just say you don't. Do you know anything about what the cardiac monitoring does? When they say cardiac monitoring, do you know what that means?
It's telemetry. You have a 4-lead placed.
Okay, so we're looking at their electrical conduction, and it is telemetry. So if you haven't worked in this area, and this is why I'm bringing this up, and if you know it, then I'm repeating something you already know, to say we got it, and then I'll move on. But with cardiac monitoring, we're looking at abnormal rhythm conduction. We're looking for beats that are not normal. And the EKG is what cardiac monitoring is. And it doesn't have to be a 12 lead. It can tell you about electrolyte imbalances, specifically potassium. So now with that being said, which of these 4 would you choose? One. It's 1. So fluid overload results, no, that's usually a different monitoring system. The presence of hypovolemic shock, no, that would actually be your heart rate and blood pressure. Cardiovascular collapse resulting from effects of excess glucose on cardiac cells, the answer to that would still be no. So with the calcium, if you are vomiting, you have diarrhea, then your electrolytes are leaving just like the diarrhea and the vomiting. So there is a osmotic diuresis that occurs with the depletion of sodium, potassium, magnesium, and phosphate. But this was specific about the EKG. So hypokalemia can lead to ventricular tachycardia. Do we want that?
Negative.
No.
You guys know what ventricular tachycardia is, right?
BTAC.
So VTAC, that's the one where they're doing CPR and defibrillating people. So if the potassium level is greater than 5, because the normal is 3.5 to 5, they're going to have ventricular dysrhythmias. So they'll start with PVCs, the premature ventricular complexes, and then that will increase over time. They will also be bradycardic, which means their heart rate will be slow. With the hypokalemia, that means it's less than 3. So when it's less than 3, the same thing happens. So your heart does not like potassium to be too high or too low. Okay. If it's too high or too low, we're looking at ventricular tachycardia for starters. All right, let's do this case study. We have a 52-year-old woman. She's diagnosed with type 2 diabetes 6 years ago. She did not follow up with the recommendations for care. She's been complaining of weakness in her right foot that started a month ago. She has difficulty with dorsiflex, or it's difficult to dorsiflex and feels numb. So basically, she can't even point her foot, right? She complains of itching rash on her groin area, and she's had that rash off and on for many years, worse when the weather is warm. She's thirsty, frequently gets up at night to pee, denies any weakness, numbness, changes in vision. She works as a bank executive and does not exercise. She's gained 18 pounds over the past year. She eats a high-fat diet, and that's her blood pressure. Sensory exam to light touch, proprioception and vibration slightly diminished on both feet. Erythematosis, scaling rash in both the inguinal areas and the axilla. Random glucose 253. Is that good?
No.
No. So remember from class, we talked about the blood sugar, right? And fasting without, and this is not having any caloric intake for 8 hours at minimum, it should be less than 126. And then if it's a random, it should be less than 200. So she's at 253. What about her glycosylated? Now, I did talk about the hemoglobin A1C. It's also called glycosylated. So make sure you know all the ways of which this is, they're talking about the same thing. So it's either hemoglobin A1C, glycosylated A1C, or plain A1C. Make sense?
Yes.
Okay. So with that being said, is this number up or down?
It is up.
It's way up because
Up.
it shouldn't be over. If it's over, greater than or equal to 6.5%, we're at 9.1. All right. Oh, well, we did a urine dipstick. Well, we checked for protein, but she actually has glucose in her urine. And that makes sense. She has no protein, but she has glucose. So anytime, and if you remember, and I can't remember if I said it, but if I did, I'm going to repeat it just to make sure everybody knows. When your glucose level is greater than 180 milligrams per deciliter, it will now spill over into the urine. So now you have glycosuria. All right, so they did a wet prep smear from the rash, and she has candida. And her ECG, it has evidence of early ventricular hypertrophy by voltage. Now that's different than the ventricular tachycardia. So basically they're saying that her heart is what? Her ventricles are what? Small or large?
They're growing.
They're
The
growing.
chambers are smaller.
Okay. So she wants to know why all of these changes have been happening to her body. What would you say?
The fact that she hasn't been controlling her glucose levels.
Uncontrolled diabetes.
Okay, so because her glucose levels have been out of control, more than one body system has been impacted, right?
Yes, a lot of atherosclerosis.
So although, she's here now, but, her nerves and her lower extremities have been affected. Her heart's been affected. She now's having cardiovascular problems, and her ability to fight infection. What we've learned about diabetics is that what? They have delayed wound healing. So with delayed wound healing, they're not going to get better real quick. It's going to take some time. Okay, so those would be things that you want to talk to her about. And is this going to be temporary, or is this going to happen consistently?
It's her life now.
It's going to happen now all time. Okay, what is the priority? And this is nursing intervention, but we're talking about what is the priority problem with her right now? What do we need to treat first?
High blood sugar.
Her blood sugar. Because if we control her blood sugar, what do you think is going to happen to all the other problems?
It's gonna get better.
Like especially her yeast infection, we're still going to have to treat that, but we could at least help it along by controlling her blood sugar, right? We're going to have to do something about the neuropathy. We got to get her blood pressure down. And why does she have high blood pressure? I mean, besides the fact she's gained weight and she hasn't worked out and she's, you know, a bank executive, which that's stressful. But what does the glucose do to your blood vessels?
She has atherosclerosis.
It causes them to become more narrow, right?
Yes.
So with that being said, we have to do something a little bit different, you know, with that. We have to understand this is going to set her up for other cardiac problems, like a heart attack. She could have a stroke. So all of those are possibilities that, you know, that would need to be discussed, so that she understands that, you know, diabetes it's a complete body problem. Okay. 3, what teaching should be done? Because, and 2, we also need to do patient teaching. So with that patient teaching, what would be the first thing to tell her? And think about why she's in this predicament in the first place.
Diet and exercising, since she doesn't do both.
Say that again, babe.
Diet and exercising, since she doesn't exercise because of her job related, and also
Okay.
because she eats a lot of fattening foods.
Okay. I mean, that is true. What else?
Being compliant.
That's the biggest thing. She needs to stick to her medication regimen. She needs to do the monitoring of her glucose levels on a consistent basis. And then we need to talk to her about how bad this really can get. I mean, make no mistake, she has some significant health problems or comorbidity now, where she may have just, you know, she may have ended up with additional comorbidities, but she has it quicker because she did nothing. And diseases just don't, you know, they don't stop because you don't do the right thing. They continue to wreak havoc on the body system. So we need to teach her about the repercussions if she doesn't change what she's doing. The blindness, she could have a stroke, she could have a heart attack, she can go into kidney failure. Do you see what I'm saying? So those things would be important to talk to her about, to say, listen, you know, although you may think this is something simple, but then talk about she could lose digits from her hands, from her toes. She could, you know, they could cut her foot off or a part of her foot, then cut the whole foot, then cut part of her leg or the whole leg, the arm, one arm, you know what I'm saying? So those would be the things you want to talk to her about if things don't change, because as the blood sugar level continues to be elevated, there's a decrease in perfusion to those distal portions of her body. So it's not going to just, you know, poof, be gone and go away. So she needs to be more diligent in making sure that she handles things. Okay. So I'm going to escape out of that. Just stop sharing. That was the end of that little piece there. Let me go to the next one. Yeah. All right, so are we kind of putting together how we need to kind of have a plan of attack?
Yes. Do more case studies.
I mean, case studies help tremendously, tremendously. Did you guys review any of the thermal regulation?
I did, but I'm driving, so I can't look at them.
Okay, what about the rest of you guys?
Same. Well, I'm not driving, but I can't look at them. I'm in the back of an ambulance.
Oh, Lord.
Oh, like,
Too funny. Okay, so let me share my screen and show you your Lippincott, and it's in chapter 51, by the way. So let me reshare my screen with you guys. All right, so what you should see is a Lippincott material. And so this is all in the diabetes section, by the way. Okay, so I'm scrolling up, but it covers it, talks about the gestational diabetes, self-monitoring, the different devices, the glycated, glycosylated, hemoglobin, A1C. So this is why I went through all of that, because there's also other names for it. So I didn't want you to be like, well, nobody told us that. This kind of tells you how the ketones come into play, so, and how they accumulate in the blood and in the urine. So, and why that's not appropriate. Then we look at insulin therapy. It talks about the preparation, and we talked about clear before cloudy, right? So this kind of gives you the spelled out way, for lack of a better analogy, of, you know, what's rapid, what's short acting, what's intermediate acting, but then it gives you the table. And so here, your rapid is your Lispro or Aspart. Your short acting is always going to be your regular, but your regular is what they're going to use for the sliding scale for better coverage. So the patient may still get their intermediate acting or get their long acting, like Detamir or Levemir. They may get that one. And then as they're checking their blood sugar, AC and HS, which is basically before breakfast, before lunch, before dinner, and at bedtime, then they're going to get coverage with regular insulin. And you can look at when it onsets, how long it takes for it to actually start working, how long it lasts for, and then what's their peak time. Then it tells you about the intermediate, which is NPH. And then here's a rapid acting inhaled version. So this is something that somebody can inhale, and it works in less than 15 minutes. It's a gas, and it attacks immediately. So, you know, when you see things like that, when you see medications, don't skip over them. I'm just, you know, I'm trying to give you the heads up. Don't skip over the medications. You need to, you know it, write it down, you know, the main common ones that are used, so that way you don't miss questions because you just, well, you know, I saw that, but I really didn't think it was going to be anything, whatever. Does that make sense?
yes.
So as I said before, if you want to know the page number, then it was 1469, if I remember correctly, is what the page number was. And then it goes into other things to do, you know, conventional regimens and intensive regimens and things of that nature. So just, you know, kind of look at it look at it from that standpoint. But, you know, here's some of the things we've already been talking about for the side effects if they don't take care of things. And it's, you know, before you tell somebody that they're about to die, nobody wants to be wheelchair bound or have a motorized scooter because they can't walk because their legs have been amputated. Nobody wants that. All right. So what do you think will help you guys now? Do you think you need more time to study and then do another Zoom session next week? Or what do you think will help you guys become more prepared? Or be as prepared as you can be?
I mean, it's a lot of information to study for me, but I am taking it day by day, just reading, taking notes as much as possible daily.
Mm-hmm.
And then during my free time, I do go over them. So that's what I'm doing now to kind of hopefully be okay for the exam that's coming up.
Okay, and you're right. It is a lot of information because you're taking 2 levels in one. So, and then
Right.
the time frame that you have is, you know, for lecture material and things like that, like face-to-face lecture material is an hour and a half, which is the reason why we tried to build in that extra time to facilitate that. So I think, you know, kind of some of the advice that I gave already will be extremely helpful in moving things forward. So let's look at look at the thermal regulation. Let's look at that. There's a couple of PowerPoints that we could do, and I'm not really sure what you guys, I hadn't looked on you guys' side today to see what PowerPoints they provided, but we'll find out in just a second. You know, where you guys stand. Sorry about that. My phone was just buzzing. And this you may have this PowerPoint. I'm not really sure. Okay. So let's do hypothermia, and then we can look at there's some case studies that we can look at. Share my screen. So do you guys have this PowerPoint?
Yes.
Okay. So did you answer these questions?
I didn't.
No.
Okay. Let's get started on it. So we have a 3-week-old infant, and it recognizes, and the nurse is assessing a 3-year-old infant and recognizes which finding as an early sign of hypothermia.
The infant is shivering.
Cool and pale.
All right, so we have the infant shivering, the other one says cool and pale.
Oh, early signs. Yeah,
As
3, sorry.
Early signs. So infants
Rectal temperature.
Infants lack the ability to regulate their temperature. And that's because they have an immature hypothalamus. So this is a 3-week-old, which is the reason why at 3 weeks we tell you to what? Bundle them up, make sure there's a little cap on their head so they don't have heat loss, correct?
Yes.
Okay. So that's the reason why we're telling you those things, is because they have an immature hypothalamus, which is where your temperature regulation occurs. So for them, this is an issue. What if the baby was preemie? Would they be more at risk or less at risk?
More.
Yes, they're going to be more at risk, because if we have an immature hypothalamus if they're born on time, if they're born early, that hypothalamus is more immature than what it would be if they were born normally. So we're looking at skin is cool to touch and pale. Okay, that would be the correct answer for that. So let's talk about temperatures. Which one is more reliable? Core temp, a surface temp? Which one?
Core.
Core temp.
And for kiddos, a core temp is a rectal temp. Okay, so if you need to do a temperature on a kiddo, that's the last thing you want to do, because once you stick the thermometer in the anus, this is all bets are off. So if you haven't gotten your heart rate and your respiratory rate before then, whatever you get now is going to be out of order. Okay. So normal temperature can regulate between 97.7 and 98.9, almost a little bit to 99. If you're hypothermic, there's several degrees of hypothermia, okay? So we have mild, moderate, and severe. Mildly hypothermic, they're, you know, between 93 and 96.8. Moderately hypothermic, it's between 80 and 93.2. And if they're severely hypothermic, they're going to be 80 and below, okay? So when we're looking at hyperthermia, then we're talking about something that's about 99 and up. What if they were like 106? What would they call that?
Starts with an H.
Hyper something. Hyperpyrexia. So pyrexia is fever. Hyperpyrexia means a very high fever. Okay. All right, so looking at question 1, why is a decrease in skin temperature an early sign of hypothermia?
They can't shiver.
They can't shiver, but their peripheries is like things are shunting to the core to support it. So their skin's going to be cold because the blood flow's not there. Why is a decrease in the core temperature not considered an early sign of hypothermia? Because I just gave you
the late sun.
Because things are going to be shunting to the core. So that it's going to be, if it's once you lose that, you're going to be behind the 8 ball. Does that make sense? So when your body's trying to respond, it usually shunts to the core, the head, brain, lungs, heart, brain, lungs, and kidneys to perfuse that area, the core of the body. So if you're waiting on the core temp to drop, then you've missed the boat. Okay, so it's the skin color that becomes pale and cool, and then pulses will be your next issue. So why do you think shivering would not be seen in an infant? Well, I've already told you this one, and that's because their hypothalamus is immature and they have not developed the mechanism to shiver. Okay, so what is a priority nursing intervention for a nurse caring for a premature infant born at 32 weeks?
Wrapping them up.
Which one? Does it say wrapping them up? You have one.
I didn't even look at the question. Sorry. Number 1?
It would be number 1. All the others doesn't matter. It's not going to fix the temperature. Okay. So we need to have a neutral thermal environment so that way their bodies can start to warm up, versus trying to, bond with the parents. That's not going to do anything. Teach the parents regarding newborn care. That's not going to do anything for this infant, because remember, if they're immature, if they have an immature hypothalamus when they're they're a term baby, then this hypothalamus is going to be a lot more immature. So we want to make sure that we do not do anything to now make them become hypothermic, because they won't be able to recuperate from that. And immunizations, we're not worried about that. That's not a priority. So we're going to try to keep them normal tensive or normal thermic as much as possible. So will they need immunizations? Yes. Do they need it now?
No.
Okay, teaching the parents about newborn care, that's not priority. I mean, you're going to teach them that anyway. Promote bonding between the infant and the parents. That's going to happen, but that's not the priority. Does that make sense? So here it asks for what is the priority nursing intervention. So not things that we know that's going to happen anyway. Okay, so you're getting a history on an 80-year-old client. So we're going from kiddo to elderly. This is our other special population group. So where the kiddos, they had an immature hypothalamus, elderly, it's what? Wearing out, okay? So they're admitted to the medical unit. The nurse learns that the client keeps a thermostat at home at 64 to cut costs on a monthly bill. Is that right? But people do it because they can't afford it, okay? What should the nurse include in the teaching plan for this client? Okay, I got your answer. Someone sent me a chat answer.
Three.
Assessment for hypothermia, okay.
Number 4. I'm between 4 and 1.
Okay. All right, so let's see. Strategies to reduce risk of hypothermia. So let's look at what the vignette says. Okay, they're 80. They can't afford the bill. It's at 64. Telling somebody to crank it to 74, they could probably barely pay it at 64. Going up 10 more degrees is probably going to be problematic. The teaching plan for social services, no, you would actually just call social services for assistance. Does that make sense? So that's not a teaching process. That's really a nursing intervention process, like calling the dietitian for nutritional management. Does that make sense?
Yes.
Okay. Assessment for hypothermia. Well, I mean, here didn't provide me enough information that I would need to assess for it. I mean, they're being admitted, but it doesn't say they're being admitted for hypothermia. They could have been admitted for something else, and this is still the situation. Does that make sense? So this is why 3, if it said the patient had pale skin or, you know, shivers or something like that, then I could see assessing for hypothermia. But since we know that they're keeping it this low, we want to talk to them about dressing warmer, layers, you know, let's get them some assistance in the interim, but you know, we still want to talk about that because we don't know exactly how quickly social services will be able to get out there. They usually come to the bedside and then try to get someone out in the community to help assist with that. But we want to talk to them about how they can stay warm. What are those sleeping bags? Long johns, okay. What is the recommended minimum for keeping the thermostat set for the older adult?
70. I don't know.
Something like that. Is 70 warm?
Yeah.
What do you guys think?
$74 because it's on the last slide.
Are you going with it because it was on the last slide, or?
Yes, I am.
I like it. I like it. Anybody? Any others?
I was gonna say 75, but something like that.
Okay. Why 74 or 75? And besides besides the fact that it was on the slide. So it should be between 68 and 70. That would be the recommended. That's the safest room temperature or thermostat temp. Think about if they keep it at 64, wouldn't the pipes burst? If it's like super cold out?
Super cold. Yeah.
So they should keep it between 68 and 70 degrees. And other things they could, you know, this would be something social services can talk to them about is they can, I'm trying to think of what they call it, where you can pay the same amount of money all year round with your light company or your electric company. There's a specific term, but I can't think of the term. But even in the summer, you know, say overall you pay, I don't know, I'm just gonna throw out a number, $1,200 a year on electricity. So you may pay less money in the spring because you don't need the heat or the AC. But in the summer, you're going to use a lot more. And then in the winter, you're going to use, when you have those super cold days, you're going to use more electricity there. But your average bill is $1,200. Then they can divide that $1,200 by 12, and you just pay $100 a month no matter what. But there's a program that, and I can't think of the full name for it, but that's another methodology of looking at it. So what is a major risk factor for developing hypothermia in this patient? Age? Would that be safe to say? That age would be
Yes.
a risk factor? Okay. What else? Their metabolic rate's gone up or down? Down. Okay. So we have the metabolic rate's is lower. They're older. Okay, what else? What about their subcutaneous fat? Do they have more? So they have a loss of subcutaneous fat. They don't move around as much because, you know, when you move around, you generate some heat with your muscles. Their diet's not, you know, adequate. So that would be some reasons why this patient would be at risk for hypothermia. Another thing, what about illness or any type of central nervous system problem? That's going to impair their thermoregulatory system of the hypothalamus. So that can set them up for hypothermia. Okay. Why should the nurse want to teach strategies to reduce risk factors in this client? Well, here, this is a financial issue, right? Yeah, the patient won't turn the heat up. It's a financial issue. So they can't, it's the inability to heat the home. And we don't know about insulation thereof, you know, their home insulation. However, you know, because your metabolic rate is much slower, you know, maybe if you get up and walk around a little bit, add some extra blankets, extra layers that will help you stay much more warmer than what you've been. Why are answers 2 and 3 not correct? And I'll go back to 2 and 3. And anytime you see something that says always, you should know that, or never, those should be immediately eliminated. But what would be some other reasons? Number one, and they asked about 2 and 3. So why 2 and 3? So referrals to social service for assistance. Well, I mean, the patient's there now. So why, I mean, again, as nurses, we need to talk about how to keep themselves from, you know, falling prey to hypothermia. And while you're there, you can assess for it. And then if family comes in, you can talk to them about it as well, how to assist. Assessment for hypothermia, there wasn't anything in the vignette to lead me to, outside of the fact that they said they kept it at 64. I don't have any other signs or symptoms that's leading me in the direction that, you know, they are hypothermic. You know, it's like slurred speech or fatigue or poor coordination, you know, slow pulses. There was nothing provided. Does that make sense?
Yes.
Okay. So with, again, infants and young children, they have an immature regulatory mechanism. Is their skin thicker or thinner as a kiddo? It's thinner. So that allows for more heat to escape. And they don't have a lot of subcutaneous fat. So their skin surface to body mass ratio is extremely high. So they're going to lose a lot of heat. And the area they're going to lose it from the most is going to be where?
Head.
From their head. Okay. So again, if you have a preemie, you have a more immature thermoregulatory system. The skin is much more thin. They have a less, you know, less subcutaneous fat, because as a term baby, they have limited. So this is going to be less than limited. And their body mass to surface ratio or skin surface ratios is still going to be higher than the term baby. Okay. And when I'm saying term baby, that's a baby that's born between 38 and 42 weeks. That's what a term pregnancy is. All right. So number 4. So the nurse is teaching a client who will be undergoing a open heart surgery about what to expect when waking up from anesthesia. The nurse explains the client will experience feeling cold, which is induced during surgery. The client asks the nurse why they induce cold. What is the best response to that?
3.
Okay, so we have 3 and so on. Ooh, come back. There we go. Okay.
3.
Yeah, so it looks like 3 be the answer. Okay. So yes, if the body temperature is lower, there's less demand on the body. So, you know, the metabolic rates reduced, they have lower cellular demand for oxygen, particularly to the brain. They use they use that, you know, for management for patients that have head trauma and strokes and cardiac surgery specifically, they will do this for, okay? So, but that their top 3 reasons is, you know, to reduce that oxygen demand so the body doesn't have all of that extra stress going on. Why do you think it would be important to intentionally lower the client's temperature during cardiac surgery?
To slow down the heart.
Okay. I agree. What does heat do to the body? it increases the heart rate, right? And that's not what you want to see happen in surgery. Why are answers 1, 2, and 4 not right? Ooh, let me go back. I'm going the wrong direction. One more. Okay, so 1 was inducing a cold environment will make the surgery go faster. That is not true. Surgery does not speed up. It will decrease the amount of bleeding during surgery. Usually if you're colder, don't you clot more?
Mm-hmm.
Okay. It will decrease symptoms related to anesthesia.
No.
And actually they have to be careful because when it's colder, they may actually have increased symptoms if they get like a bolus of as they start to warm the patient back up. So that's not a true statement. So even when you're caring for your hypothermic patients, you know, certain medications, because the body temperature is colder, it's not going to move around in the body system more. So, you know, it's not to decrease the symptoms related to anesthesia overall. Okay. I apologize for that. I mean, I can't do anything about that. That is the most irritating thing of all time, by the way. We're moving on. All right, so here's some key points to hypothermia. So the condition where the body temperature is less than 36 degrees Celsius. Hypothermia occurs when the heat the body produces is less than the heat loss. And we lose heat through a variety of ways, right?
Yes.
Okay, so radiation, so we're transferring heat from one surface to another. So it's like when you sit on like a plastic chair, if your arm touches a table that's been out to ambient air, then you're going to lose some of your body heat to that. Then you have conduction, where the heat's transferred from one molecule to another molecule of lower temperature. Convection is where we have a dispersing of the heat by air currents. And then vaporization is where it's a continuous evaporation of the moisture from the respiratory tract or from the mucosa of the mouth and the skin. So those will be your ways of losing heat. It can also be a life-threatening emergency and can occur in any season. So, you know, you can be out in, you know, the water at the beach and end up with hypothermia. So you know, it's not always just because it's hot outside, you won't get hypothermia. And can you pronounce a person, you know, who's hypothermic dead? And if so, under what situation? If the patient has obvious signs of death, like rigor mortis, I don't think you need to warm that body up. Does that make sense? Because you technically can't pronounce a person dead unless they're warm and dead. But if they have dependent lividity, you know, rigor mortis, then those are for sure signs that that person is DRT, dead right there. Okay. All right, so these are types of hypothermia. Induces what we just talked about. Accidental, this is an immersion in cold water or cold water exposure, or the body tries to conserve core temperature at the expense of the extremities. Routes of heat loss, we've already talked about that. I gave you the convection, the radiation, conduction, and evaporation, so we've already covered that piece. Core temperature is usually higher than skin, and there's a greater difference in temperature the more rapidly heat transfers. Depletion of glycogen stores and brown fat. So here's reasons for induced hypothermia. This is what happens: lower cellular demand, used to reduce neurological damage, is a sequelae from post-cardiac arrest, lessens anoxia. The goal is for the client temperature to be at 33 degrees. Stop all potassium administration during rewarming. I'm gonna move that out the way, move that up here. And also sedation or paralytic medications. Accidental, that's a cold exposure, immersion in cold water, or lack of adequate clothing, shelter, or heat. So that would be our patient. Associated with near drowning, and usually if it's a near drowning, it's no longer near drowning, it's just strictly a drowning whether you actually die or not, okay? Ingestion of alcohol, drugs, trauma, and then sepsis. You can have cold sepsis. Newborns, large body surface area to body mass, limited insulating subcutaneous fat. They lose 4 times as much heat as adults. Their thermoregulatory system is stable. Their heat losses is through radiation and convection. Thermal conduction is marked difference between the core and skin temp. So cool environment to peripheral vasodilation. Thermogenesis, muscular activity, non-shivering thermogenesis, skin receptors, the brown adipose tissue or brown fat. So review that information about the brown adipose tissue is depleted, and the metabolic response metabolic response to cold is limited. So the increased basal metabolism increases oxygen consumption. Decreased environmental temperature doubles oxygen consumption. So we want to keep a newborn warm to promote normal oxygen requirements. Preterm newborns may be unable to increase ventilation. And this will now, the ability to generate heat can be altered by hypoxia, acidosis, hypoglycemia, because remember they have high metabolic demand. And there's certain medications that can also facilitate that. Okay. And you can see newborns don't. Distribution of brown fat is in, that's in the newborn, it's in the core between the scapula and at the kidney. So we've already talked about this. Chilling can cause respiratory distress. Preterm infants, they are unable to increase their ventilation, so they need extra protection with mild variations. We talked about the elderly sensitivity. So decreased thermoregulatory control, loss of subacute fat, environmental factors can't pay the bill, or it's to stay warm, illness or central nervous system disorder. And then this actually goes into the different types of hypothermic injuries like frostbite, which you will need to know, FYI. What areas are more prone to frostbite?
Fingers, hands, toes.
Ears, nose, feet, and hands. So unless you're wearing a ski mask, your nose would still be exposed, but your ears wouldn't. And that would look kind of creepy. So it's just something to consider. If the tissue freezes, what will it look like? More like as the tissue freezes, they can develop ice crystals, which increases intracellular sodium content. The small vessels cannot vasoconstrict. Okay. So if they can't vasoconstrict initially, then they vasodilate, and then they become more permeable. So therefore, the cells will then swell, cause swelling to the tissues. The more they are exposed, then vasoconstriction happens. The blood gets more viscous, and it can lead to infarction or necrosis of the tissue. So here's what I was just talking about. Here's frostbitten skin. Look how pale it is. So it could be white or yellow. It's going to have some loss of elasticity. Now this here, they've been out there a while. Okay. Is it the decrease in temperature outside that causes frostbite, or is it the wind chill?
The temperature outside? Oh.
It's the wind chill.
The wind chill.
So, and I'll tell, if it's, just think about the, 48 hours ago, or it was 30, it says 37 degrees, but then it says it feels like 32. Does that make sense? Or it was 32 degrees, but it feels like 26. Mm. It's the wind chill. As that wind breezes by and your skin is exposed, it is wreaking havoc on your skin. So it's the wind chill factor more so than the actual decrease in temperature. And if there's any humidity in the air, usually it's a lack of humidity. But yes, thawing of tissues, this is what it would look like: yellow skin, loss of elasticity, burning pain, etc. So you kind of read that already from earlier. Folks that are at risk, we've already covered that and the reasons why. Illness, acute or chronic, malnutrition, although that's there twice, medications, and certain medications like Demerol during labor can prevent metabolism and decrease the body temperature. So we talked about the immaturity of a newborn, of the hypothalamus, and then we have if it's a preemie, then that's going to be a bigger problem. So I believe, as you guys said, this was already in your course board. So, look back over that material. I don't want to just repeat the same PowerPoint unless you have a specific question about something in the PowerPoint.
No.
Okay. All right. So we have about 12 minutes. What would you like to do?
Breathe.
All right. The last thing I will say outside of, other things, teaching about risk for hypothermia, making sure we talk about layering of clothing, having hats and the appropriate gloves. Those will be the things to help minimize the risk. Identifying when you are having hypothermia, your fingers start to tingle and, they feel tight, then you need to go ahead and, address that, like go inside. Now, my next question is, do you put it under hot water?
No.
No. So you need to let your extremities warm up naturally. Now, can you put dry, thick socks over them?
No, you don't want pressure on it, right?
You can put dry warm socks. That allows the body to heat up naturally. You could put it under a blanket, not a heating blanket, but a blanket just to allow your body temperature to increase. So I'm not talking about someone that's like, even if, frostbitten, like even with the dark fingers, you want something that's going to warm them, but you don't want to add any additional radiant heat, because if those nerves are damaged, then they can't tell you that it's burning their skin. Does that make sense?
Yes.
Okay, so that's why heating pads and heating blankets isn't a good thing. But if you just have a regular blanket and you wrap up in it, then that's different. Okay. Let's see what else. I think that's about it. We covered everything there. But that's why it says that have that neutral thermal environment. So that way you don't do anything extra. But you can turn the heat up if if you're not elderly and can't afford it, then that would be also something good. Space heaters, you got to be really careful with that because you get too close to it, that may be an issue. And if you put it too close to something, that may be an issue and cause a fire. And we don't want that to happen. Do you guys have hyper or hypothermia case studies on your side of the house?
I want to say we do.
Oop, let me look. Let's see if I can find. I'm looking. Give me a sec. And so do you guys look at those things beforehand or do you kind of look at it at some particular time?
I look at it beforehand. I'm already looking at the information for next week. So I'm just trying to backtrack.
So yes, they do have an imbalance, thermoregulatory imbalance, which is the blue PowerPoint that I just went through. And then there's let me go back to it. There are case studies, and I want to see if it has the, yeah, there's a case study here with the, it was July 20th in Houston for hyperthermia. So, I would try to answer those questions. What's the difference between heat, stroke, and heat exhaustion? And then if you have heat cramps that's an electrolyte imbalance, but if they have nausea, then we can't give them oral hydration. They need IV hydration, nausea and or vomiting. So although the temperatures here that are listed are pretty high, it looks like 104, it's really about the humidity in the air, because if the humidity's thick, then the person can't sweat, and it's much harder for them to recuperate from that. But when you're looking at heat exhaustion, then your skin temperature or your skin is more damp from the sweating. When you're looking at heat stroke, then you're going to have arid, dry skin, which means it's going to be dry as a bone. There'll be no sweating. But that can happen at, it doesn't have to be 200 degrees outside, and I'm exaggerating, but it doesn't have to be that extremely high in order for there to be a problem. So just kind of some food for thought there. All right, guys. I will leave on that note unless there's another burning question that you can think of.
Thank you.
I don't have anything. Yes, thank you.
What do you guys think will be more helpful for you moving forward? Because I want to make sure that it's also representative of what you need.
Well, personally, I haven't figured out what I need.
Okay.
So, and like I said, I'm just trying to look at everything and study it and go from there.
Okay. Anybody else?
I guess I need to start. Go ahead, Jacob.
After the first test, I'll have an understanding of what exactly I need to study. So I think that's where I'm waiting for.
Yeah.
So once I post this, then, and your classmates review it, then hopefully on Tuesday, there'll be more, these are things that I need. This works for me. I learn best when X, Y, and Z. So that way, because every group is different. So I try to follow a similar format. It's not a one size fit all, but if you follow it, like I said earlier, looking at the pathophysiology, understanding, how these things come about, risk factors, signs and symptoms, diagnostic studies, so that include lab values and/or X-rays or CT scans, and then what's your interventions and patient teaching. And your Lippincott advisor does the same thing. So you guys know how to access that, correct?
Yes.
Are you the only one?
Access what? I'm sorry.
Lippincott
advisor.
Yes.
Okay, so it's kind of laid out like that. And then once you understand understand that component, like your signs and symptoms, et cetera, et cetera, et cetera, then I would go and see, do some of the case studies and answer the case studies. So, and then use your book as well, not just the Lippincott advisor, but also use your book, because that's just an outline. So if you need some more teeth behind it, then, take the necessary steps to have some teeth behind what you're trying to do. Sounds good?
Okay.
All right,
Yes,
babe.
ma'am.
We'll see you Tuesday. Be good. Have a good weekend.
See you Tuesday. Thank you. You too.
8:30.
Thank you. Bye-bye.
We're actually been moved to 329. So P329. That's our new room. And we shouldn't
Okay.
do any more after that. They speak all week.
Thank
Okay.
you.
Sounds good. Thank you.
You're welcome.
All right.
Bye-bye.
Bye.
Bye-bye.